LBBAP lead implantation procedure with SV separation as the endpoint, John Jang's method. First, determine the lead insertion site. Using the line connecting the annulus apex and the cardiac apex as the axis, a fan-shaped area corresponding to the middle and lower two-thirds of the tricuspid septal leaflet is formed as the lead insertion site. Adjust the parameters of MEA. Filter amplitude clipping setting. Principles, full display of EGM morphologies within the viewport area. Validity setting, observation of SV separation for the purpose of maximum filtering of low-frequency signals, setting allowed by the device. Safety settings, avoid perforation and guide the screwing speed. Reasonable settings of amplitude, matching clipping, facilitate the observation of injury changes throughout the lead implantation process. Unipolar connection of John Jang's connecting cable. Under 2V continuous pacing mapping, screw in the lead. If loss of capture occurs during the process, screw in the lead under the lowest output capture. Low output electrical stimulation, pacing, ECGs, are usually morphologically identical to mechanically stimulated premature beats, PBs, although the lead traversed between different tissues to easily trigger PBs, but still by chance. A constant rise in COI is a sign that the lead is effectively screwed in, and at this stage it can be screwed in quickly. In the RVSP to DSP trip, COI is a continuous rising process until the initial LVSP appears, the COI reaches the highest peak and then gradually decline. After loss of capture at 2V in this case, we increased the output to 2.5V but still could not achieve capture. Then, increasing to 3V achieved capture. Subsequently, it was still necessary to reduce the output to ensure low output capture, ensure an acceptable LBB capture threshold. With the occurrence of transseptal PVCs accompanied by the transition of DSP to LVSP, COI further increases to reach peak. After the presentation of LVSP, increase the frequency of impedance measurements, focusing on the differences in ECG morphology between adjacent beats and the changes in V6RWPT. After LVSP presentation, COI then entered a downward trend, appropriately slowing down the lead screwing rate. Comparison of ECG morphology differences and V6RWPT changes at the default 5V 0.5 ms impedance measurement output of the Medtronic 2290 versus 2V 0.5 menisses, or the lowest capture output. When there is a shortening of the V6RWPT or a change in ECG morphology, e.g. a new S-wave in the V6 or a deepening of the existing S-wave in the high-low output, the screwing rate needs to be further slowed down. When a sudden change in ECG morphology occurs in two adjacent beats with or without V6RWPT shortening, it is necessary to pause the screw-in and lower the output to observe the SV separation. Such sudden changes in the ECG include 1. V6RWPT abruptly shortened by greater than 5 milliseconds after LVSP. 2. Appearance or deepening of the S-wave in V6. 3. SV smooth interval. 4. LBB premature beat. 5. Emergence of an initial R-wave in V1. 6. Sudden reduction in R-wave amplitude across left chest leads. In this case, when output voltage decreased from 2V to 1.5V, a clearly visible SV smooth separation interval appears in the EGM. When SV separation is not present, the COI permits careful screwing in at minimum capture output until separation is achieved. Of our 3 in 21 SV separations, 194, 60.4%, were seen separating at reduced output, and the other 127 were carefully screwed in at maintaining the lowest capture output until separation. Maintain SV separation, perform RVS angiography to observe the depth of lead screwing, optional, and then continue to withdraw the sheath while maintaining SV separation. The next step is the routine pacing parameter testing. Focus, tip unipolar DLVS and LBB threshold. Tip bipolar, then it needs to be specified separately RVS, LVS, LBB triple thresholds. From April 2021 to November 2024, a total of 365 consecutive patients were planned for LBBAP, successfully achieving LBBP 338 cases, accounting for 92.6%, of which 321 cases, accounting for 87.9% of the total cases, used EGM with SV smooth interval as the basis for SLBBP. This is a DCM patient with LBBB. It shows his blood pressure changes with LBBP. And without pacing, summary of key points of the John-Jang's method. 1. Tricuspid valve angiography to clarify the relationship between the septal and posterior leaflets. Positioning of the auxiliary lead screwing point. 2. EGM dual channel setting. Effectiveness and safety of auxiliary monitoring lead screw-in depth. 3. EGM parameter settings based on the principle of fully displaying potentials within the window range. 4. Continuous recording. Screwing in the lead under low output pacing mapping. 2V Nzembim infinims or the lowest capture output. Key points of lead advancement. Elevated COI indicating endocardial injury. Transition from DSP to LVSP. Initial appearance of V1R. Transition from LVSP to NS-LBBP. Appearance or deepening of V6S or shortening of adjacent V6RWPT by about 5 MEs. Reduce output to observe SV separation. Finally, let's once again review tricuspid angiogram, performed on the same patient at RAO 30 degree, top row, and LAO 45 degrees, bottom row, with septal leaflet left and posterior leaflet right angiography. It should be noted that when the sheath is rotated clockwise and naturally enters the RV through the posterior leaflet to locate the septal leaflet insertion site, it is usually necessary to perform a deep bend shaping of the primary curve of the sheath.